probably the number one reason why elderly fall is not because they're weak. It's usually because of their balance reactions,
yeah.
right?
Yep.
That's why I tell so many guys, stay out of fruit trees, stay off the ladder, stay off the roof. You think you can do it, but you cannot.
I've had patients come back to my clinic and they said, oh yeah, the physical therapist is showing me how to walk again, heel to toe. They don't even know they're walking abnormally. They really don't know that they've created a new pattern of walking.
You know, your brain just perceives it as normal. You have to unwind that neuromuscular memory, per
Yes.
se, right? And then teach them the correct way to walk, which is way more efficient once they learn it.
Okay, welcome everybody to another episode of From the Inside Out, where Lehua and I interview specific specialists to talk about different topics. Today's topic is going to be, well, we have two episodes actually. The first part of this series is going to be on physical therapy, the do's and don'ts after hip and knee replacement surgery, and we'll be discussing options on that. And the part B will be physical therapy concerns or issues for following pregnancy or birth, particularly with C-sections or natural childbirth and other OBGYN related physical therapy questions and topics. So today we have with us a good friend of mine. We actually went to high school together.
Punaho.
Yes, and
You didn't warn me.
We played sports together. So he and I saw each other naked many a times in the locker room. Yeah, that's how close we are. So Chip, here we have today Chip Yamaguchi, who is graduated from Punahou School, and I think Chip, you got there in 7th grade, yeah.
9th grade.
Oh, same like me. So I came there in 9th grade as well, and so we're both public school, and then went to Punahou.
Where'd you grow up?
Grade.
In IAEA,
Oh,
Pearl City.
IAEA.
Yep.
Graduated from Punahou School. He then went to the University of Oregon, where you said your undergraduate degree was in psychology.
Yeah.
And got a bachelor's of science, and then went to University of Puget Sound, where he got his master's in physical therapy, and now is the co-owner with Kat Koike
Yeah.
of an outpatient physical therapy group called Stay Fit in IAEA, and they have an office in Kapolei as well.
Yes, that's right.
He is an orthopedic certified specialist. I got his certification back in 2000 till 2010. He's a certified strength and conditioning specialist and a certified Graston technique practitioner, as well as functional movement screening level 1 and a National Academy of Sports Medicine stretch and flexibility coach. Is that correct, Chip?
Yes.
Wow.
And you also serve as, I don't know why this is, you also worked at many places before starting your own physical therapy group. So he has a lot of experience. He used to work at Rehab Hospital of the Pacific, then at Wahiawa General Hospital in Central Oahu, and now is a volunteer physical therapist. And I think you do work for the University of Hawaii men's volleyball team, correct?
Yeah, for the past maybe 3 to 4 years.
3 to 4 years. We've had a good working relationship with Chip. Chip has also come to our orthopedic clinic at Straub, where he's actually physically spent time learning from one of our shoulder and elbow experts, Dr. Ed Weldon. So he's sort of our go-to guy for people who have serious problems with like frozen shoulders or therapy post-surgery for shoulder and elbow, and also does a lot of hip and knee outpatient physical therapy as well. So he has seen a lot of our patients, and we're here to talk about part 1 is basically issues with outpatient physical therapy, its importance, and things like that. So anyway, welcome, Chip. Thanks for being here.
Thank you. Thanks for having
That was a
me.
long introduction.
That was a
but
long one.
That's what happens when you're old.
That's right.
Yeah.
Yeah. When you're young, you don't have much of
You
an
only get like two lines maybe.
because you haven't done anything. Yeah.
Yeah.
So, I'm not sure exactly how to start this, but I guess my question is, let's start off with knee replacements. I think a lot of people ask, like, how important do you think physical therapy is after.
Well, can I ask you one question?
Yeah, sure.
After you get a knee replacement or a hip replacement, is it automatic that you go to a physical therapist, or
Okay.
it's a choice by the patient, or
It's
is it
actually a choice by the doctor. So it's kind of
okay.
interesting. Obviously, the orthopedic surgeons have varying opinions on the importance of physical therapy.
Okay. So it's not a
after-
standardized
It is not
idea
a standardized thing. There are some orthopedic surgeons who do not believe in sending their patients for outpatient physical therapy following hip or knee replacements.
Okay.
And in fact, I just came back from Arizona where I met with a bunch of other joint surgeons, and there are a few guys there that do not send their patients following hip replacements for therapy. They feel like it's not necessary.
Anterior hip replacement.
Anterior hip replacements. Yeah, they feel like it's not necessary because people, recover really pretty quick. I feel differently. I think
So it's very doctor dependent.
it is doctor dependent. If you look at the literature, there's literature that says that they can't really show a difference whether people do go through physical therapy or whether they don't go through physical therapy. So there's different
Interesting.
opinions, but I do feel that it is, for my patients, I always send them for physical therapy because I feel like there's a lot of things that change as you get older when you're living with, like nobody has just bang arthritis and then they go to get their hip replaced or their knee replaced and then they just get back to their normal self, right? They've gone through years, months and years of a slow adaptive decline
Yeah.
in dealing with their painful hip or their knee that really has started to almost train themselves to walk in an abnormal manner.
That's true.
That
You change
you
the way
adjust
you-
yourself, right? Because if you have a sore hip,
Your gait,
you're
your
gonna walk differently.
posture, yeah.
You're gonna do things differently, and people don't realize that. This is my opinion, right?
Mm-hmm.
It's hard to prove, but people don't realize that as they do that, they've actually changed how they walk. So, if let's say grandma or grandpa had a hip replacement,
Yeah.
and then we do the hip replacement for them, right? They may still continue on with those abnormal gait patterns
Even after.
that's been embedded in their brain from having walked like that for the past decade, right? With the
Right.
slow decline. They don't even know they're walking abnormally. So when patients tell me or physical therapists say that, oh, we're going to teach you how to walk again. In some ways, I think that's true.
That's true. The
What are your thoughts on that?
years and years of compensation. Your brain just perceives that as normal.
Yes.
So you have to unwind that neuromuscular memory per
Yes.
se, right? And then teach them the correct way to walk, which is way more efficient once they learn it.
Yeah. So, I've had patients come back to my clinic and they said, oh, yeah, the physical therapist is showing me how to walk again, heel to toe, right?
yeah.
Which a lot of people sort of
yeah.
get out of doing, right? This point about they don't even know they're walking abnormally because it gets retrained, right? Like I said, 5-10 years people go with living with arthritis before it gets bad enough that they may have a hip or knee replacement. During that time, they really don't know that they've created a new pattern of walking.
Right.
What's the best way to, a neuromuscular, they've trained themselves to walk differently.
Right.
And it's hard to get you can't just, I tell people, you've had 10 years to develop this abnormal gait, right? Or this abnormal walking pattern. And in 30 minutes, we're going to change your hip. Right?
That's right.
30 to 40 minutes is what it takes for a hip replacement. You're not going to all of a sudden come back to 100% normal
because
after your surgery.
You're right, because that motor pattern, that movement pattern is, again, interpreted as normal after walking, incorrectly, I should say, for years and years, right? So, obviously walking, it's like when the average person walks, you don't think how you're walking, right?
Nobody does.
It's like a friend of mine once told me, the best example of that is say you take a bath and you dry yourself off. It's not like you think step by step, okay, I got to wipe my back, I got to wipe my foot. You just do it the same pattern day in and day out, right? Without even thinking about it. And walking is the same thing, right? So you're right. If someone has an arthritic hip and it's tight or the leg length changes because they're in varus, right? Their knee is bow-legged, then their body starts to, and their brain starts to interpret that as normal.
Yes.
Right. So all of a sudden you go in 30, 40 minutes later, you put a new joint in, and the body sometimes has a hard time adapting to that.
So me personally, I think physical therapy is important for those reasons. I think it's also important that the patient get contact with a medical specialist, because physical therapy, like when we order knee and hip physical therapy, it's usually 3 times a week, right? After surgery, until physical therapist starts to see improvement, then you might cut it down to what, twice a week,
Twice a
and
week.
like once a week, and then you graduate, so to speak, right?
Especially the knees.
Yeah. So I usually order physical therapy for standard is like 6 weeks. But the good, a therapist will tell us if, hey, Mrs., I'm just using an example name, or like Mrs. Nakasone needs a little bit more. She's a little bit slower. So, can we extend our therapy? And a good therapist will do that and will send it to us and say, hey, she needs a little bit more time. Because not everybody doesn't recover at the same rate.
Right.
Some guys are really good and maybe they only need 4 weeks and then they're good to go, right? They exercise, they understand the exercises, they can do it on their own, right?
Right.
But other people are obviously slower. We have
It shocked me though, after, hip or knee replacements, you guys get them up like that day and
Yeah.
walking on it. I don't know why I was shocked by that, but I was shocked that.
Well, I think most of our patients are also shocked by that. They're thinking, wait,
yeah.
you just operated on my knee or my hip or both my knees and both my hips.
And you want me to
and you want me to get up now, like the same
stand.
day? They think we're crazy, but
Yeah.
they don't realize that they can, right? And
Right.
I should take that back. Depending on the functional capacity of the patient,
True.
they some may not. If I'm
Yeah.
operating on an 87-year-old
Right.
lady,
Right. But for the most part, I was shocked
the
if you're
most part, they
younger
can, yeah.
and wow.
Yeah.
You guys get them up real quick.
Yeah, I think, we're going to, I would like to interview one of our inpatient therapists to talk about some of the difficulties or the challenges that we see with inpatient therapy, because by the time Chip them get them there already,
Yeah. How much after the surgery do you send them
depends.
to the outpatient?
we start within, I would say within 5 days, right, Chip? Generally.
Usually.
Oh, that's
Depending
fast.
on
Yeah.
availability of the therapist and patient, right? If they're, say like they have surgery and then they get discharged,
Yeah.
and then from the time of discharge, maybe, somewhere, hopefully within the week, right?
Yeah.
They get
usually.
seen as their first evaluation, and then the therapist will schedule their follow-up appointments with them accordingly. But some of our patients that say had surgery are not quite functional enough to go home. They'll go to a rehab
Rehab.
hospital, the Pacific, stay there for 7 days,
Yeah.
10 days, depending, until they have the basic safety to just go home. Then they start their outpatient therapy.
Got it.
Yeah. Sorry, getting back to that topic of abnormal walking thing, this is very important because, like, in the case of hip replacements, actually, even in knee replacements, right? Patients, a very common complaint is, oh, my leg feels longer or my leg feels shorter or whatever, right?
Okay.
Like they feel they're uneven.
Okay.
But it's interesting, if you ask patients before, so let's say you have an arthritic hip, only one hip. Usually your arthritis hip is a lot shorter than your normal hip.
Okay.
And there's 2 reasons for that, right? The cartilage is actually, the bone has gotten higher because it's eroded the cartilage.
Cartilage, yeah, it's gone.
But it's also more likely that you have a little bit of a hip flexion contracture. So
Hip flexion contraction.
what that means is you cannot straighten your hip all the way out.
Oh, okay.
So you end up walking a little bit bent over. So
Oh.
effectively, that leg is shorter, right? Because they can't straighten that out
Yes.
as much. That's very difficult sometimes for people to understand.
Yeah.
But when we fix your hip, now you can straighten that hip all the way. So now you can stand normally. But if you ask them before surgery, do you feel like your leg is shorter? Most patients will say,
no.
no, because they've had incremental changes over a year or 2 years or 3 years or 5 years, right?
Slow change.
So the brain resets what is normal.
Yeah.
Yeah.
And then we fix their hip, and all
And
of
you
a sudden they
compensate
feel like,
for
oh
it.
my God, my hip is too long. Why don't my leg feels too long? But when we show them the measurements,
Yeah.
that it's pretty much as humanly possible. We're pretty good about getting the leg lengths and offsets equal. Then most people will understand. And of course, this is a very, very complicated topic because if I do a hip replacement and you have bow legs or 2 knees are not equally as crooked, one is more crooked than the other, then obviously you're still going to be a slightly uneven.
Yeah.
People with scoliosis or degenerative arthritis in their back where they have some,
Oh, right.
that of course affects how you perceive your leg lengths to be as well. So Chip them have a very unique, talking about leg length discrepancy, a great way, a very smart way of dealing with that. So if we have can you explain what you do for a patient who has had a one-sided hip replacement and they feel like their leg is too long or it's usually too long.
Too long.
Because they feel like, oh, all of a sudden my hip is longer.
My hip is longer.
In fact, it's almost never they feel like it's too short.
Yes, it's almost never they feel like
I
it's too
usually
short.
tell them that, when they, whether it's a hip or knee, I tell them they didn't make your surgical leg long. They made it normal.
Yes.
So the left, usually, if you have arthritis of your right hip, you probably have some in your left
the other side.
too. So I say the doctor didn't make it long; they made it normal, and you probably feel to some degree that your other side feels short. So what we normally do is we use a heel lift, usually what we call an adjuster lift. So it's like, I don't know, maybe up to half an inch, but usually we don't need that much. And then you can just peel away about 1/8 of an inch at a time.
Oh.
And interestingly enough, people initially they stand and they're like, wow, my heel is this far off the ground now. And then amazingly over a course or a number of weeks, you take the lift away and they feel perfectly even.
Oh.
So, we've had long discussions about this. And then that leads into the topic of the decision when somebody has bilateral hip or bilateral knee arthritis, right? I know that usually you'll choose to do whichever one is worse, right?
So for me, yes, true. Obviously, your most symptomatic hip. So whether it's your right or your left, if that's the one that hurts the most, and the other hip really doesn't hurt, and it doesn't have a lot of arthritis, then obviously we're only going to recommend one. But we published a study looking at the prevalence of bilateral arthritis in patients who came in complaining of only one side. So let's say you looked at all of our patients with knee arthritis who came in saying, oh, my right knee, or whatever, right? I always take x-rays of both knees and both hips because I need to see what the deformity and what the damage is on the other knee, right? So what we found is that 95% of patients that come in, 90 to 95% of patients that come in with complaints of only one knee pain already have arthritis on the other side.
That's super high.
Yeah, it's very high but it makes sense.
That makes
because
sense, yeah.
arthritis is just a part of aging. You're not going to just develop gray hair on one part of your head, right?
I don't know. Mine's is on one side over here.
Well, maybe you're lucky. You're gonna have the sexy, the Tulsi Gabbard sexy stripe, But you know what I'm saying, right?
Yeah.
Arthritis is attacking your whole body as we get older, so it's very common. And for hip arthritis, it's like 70%
That's crazy.
that have already evidence of arthritis on the
Other
other
side.
side. So if they have arthritis on both sides and deformity on both sides, and if they're also symptomatic, and because most people, when you ask them, does your other knee hurt? They're like, yeah, but not as much as my right knee. I'll recommend to them that we just do it at one time because it saves them a second surgery. I can make both legs more equally symmetric at one time than having one crooked leg and now one straight leg from surgery, right? Because then, you're still not going to be normal.
Yeah.
But other surgeons feel very differently. There are other surgeons that really do not believe in doing bilateral hip or knee replacement surgery. There's literature on both sides that say one has more complications than the other, and vice versa. So I think
Oh, interesting.
the literature is not clear on what is safer or what is not safer, and it also depends on the surgeon, right?
Right.
And how comfortable you feel about it. But
Well, it also saves in rehab time because for somebody who has both hips or knee done, it's not like you're in therapy twice as long.
that's right.
So you might be there, I don't know, maybe 1.5 times as long, maybe not even that.
Yeah.
Because you're going to be treating both knees or both hips at the same time anyway, right?
Yeah.
So it saves in terms of cost to the patient and the insurance companies. It does save to have both done at the same time.
Yeah. The other thing too is I found that for for patients that are still working, like I mean, obviously for patients that are retired, if they really, really want to have them done separately, that's fine. They can take off. They don't have work to worry about. But if you have a patient who's like, say, 60, still working, it's very difficult to be able to take off work twice in a year, right? To get 6 weeks
Plus,
off of
too,
certain
if
work.
it's sore, which it is,
Yeah.
you're less likely to go back and experience that pain again, right?
Yeah, it's true. Or you're gonna put it off, but that
Because
whole
even if you
time-
do have it on the other side, but you're less, it's painful,
Yeah.
but it's less so, right?
Yeah, so you're not really quite as happy, right? Because you have one good hip, but you're still not ready to go traveling and whatnot because your other hip's bothering you. You're working, you cannot get another time off work, so you got to wait till next year to get your hip done.
Yeah.
And, so for many reasons, I think it's beneficial to people, and at least for our data at Straub for
Yeah.
my patients, we couldn't demonstrate that there was an increased risk of complications doing both or doing just one at a time. And we're still
That's good to
obviously
know.
collecting studies and doing research on that. So, but that's given me more, how should I say, ammunition or more reason to be more liberal with offering hip and knee replacements for both sides. Right?
This question may not make sense, but from what I understand, simple mind, you said the knees are more painful for people than the hip. So are you less likely to do a bilateral, offer a bilateral knee surgery because of that? No.
Yeah, but maybe you can speak to that because I think it's very clear from experience and also just from how patients do. People always think hip replacements are going to hurt more than knee replacements. They think that.
Yeah, that's not true.
But knees are I always tell people just prepare yourself.
Really?
Yeah, we haven't been able to. There's no medicine or no technique that has made post knee replacement surgery fun. You know what I mean? It's not an easy time. Hip replacements. I don't know. Maybe you can speak to that and on what some of the differences you see between people undergoing like an anterior approach hip replacement and a total knee replacement.
Oh yeah, total knee replacement unilateral is bad enough. And if you've ever watched a replacement surgery, you would know why. So I kind of laugh sometimes when patients say like 2 weeks later, like, "Oh, I don't know why, but my knee is still sore." I'm like, I said, have you watched the video?
Yeah.
So, and then, bilateral knee replacement generally is like not twice as sore, it's probably 4 times as sore.
Really?
I don't have twins, but I usually will actually tell patients it's probably similar to having one child versus having twins. It's probably not twice as bad. It's probably like 4 times as bad in terms of energy expenditure, right? So on the parents, I mean, right? So taking care of the kids. But bilateral hips, people tend to do really well. They kind of waddle around when they first come in. But pain level wise is generally not even close to bilateral knee replacement.
Wow.
Yeah.
And you guys haven't figured out a reason why that might
I
be?
think like some joints tend to be just more painful. Like shoulders, like Ed Weldon, and the other shoulder surgeons tell me that shoulder surgeries are painful.
Wow.
You're right. Yeah.
Shoulder and I would say maybe even elbow too. Yeah.
We have I've seen a small sample of individuals who've had knee replacement, hip replacement, anterior hip replacement, right? And either a rotator cuff repair or a labral repair in the shoulder. And they say that the shoulder surgery is the worst.
Really?
Oh, yeah.
Shoulder.
Yep.
Is it just so much nerves, maybe? Nerve
Yeah,
endings
that's what
and
I think. I think there's probably just, again, simple mind, right? Just to explain to people. I'm like, if you walk and you bump your okole on the coffee table,
Yeah, not so bad.
It doesn't hurt that much, right? You're like,
I get plenty padding.
But you hit your knee on the coffee table. Oh,
Sore.
that sucker is sore, right? Because there's really no...
or your funny bone, right?
Yeah, there's no cushion around your knee. There's just skin
Yeah.
and bone, right?
Yeah.
So you
hurts.
fall on your knee. Oh, God,
It's true.
that hurts, right?
Yeah.
And I would just imagine shoulders and upper extremity, the innervation patterns
Yeah.
are just,
It's the
because
nerve.
we have to be more dexterous. You have to know, I mean, you can't have a dumb shoulder, otherwise you're not going to know where your hand is in
Yeah.
space, right? So I that's my simple explanation for why just some joints are more innervated or, or just evolutionarily meant to be more protected, right? So
But you know what's interesting about pain after surgery is that the younger individuals seem to have more pain.
Oh,
right?
100%.
Really?
Yeah.
Yeah.
Or is it going back to what you were saying where people lived with it for so long?
No, I think it's so. I think there's two. This is my, my opinion about it is that I think it's two reasons, right? It's like as we get older, all our bodies are slowly dying, right? So everything.
that's
I know
depressing.
that's a depressing thing to think, but
True.
that's the reality.
Yeah.
All of our senses are getting worse.
Yeah.
When you get older, your hearing gets duller. Your sense of taste and smell are not as good. Your vision is not as good. Your reactions are not as good. Your
memory.
nerves are not as good. Your memory is not as good.
Your memory.
My memory was never good.
What were you saying? No.
But yeah, stop interrupting me.
Sorry.
God, not what I was talking about. Anyway, but everything is getting duller.
Yeah.
Right? I would say young people, because they're still vibrant and all of their nerves and their feedback mechanisms are healthy.
More reactive.
Yeah. It's funny because, like, speaking of that, right? We'd be at, when I was at the Army hospital, I've got these big young guys, right?
Yeah.
Some
Fit.
cut on their hand, right? And they're just like, oh my God. And you're
This
thinking
is
to yourself,
men,
oh my
though.
God.
This
You're
is
like, oh my
men.
God.
Men
No, but
just,
I think,
baby.
I think there is some truth to that. So the other thing that I tell people is like, if you took a young guy, like say our age, younger, okay, maybe say 30 or 40 years or whatever, and they fell off their bike and they broke their hip, just laying in bed, they would be in agony. Like you cannot give them enough pain medications to cool the pain. An 87-year-old demented lady
Yeah.
who falls down and breaks her hip can be lying in bed and have no idea she broke her hip. As long as you don't move her. Once you move her and the
Then
bones
you
move,
saw.
it's like then they wince and they're obviously in pain.
Yeah, that's
but then
true.
if you leave them alone, they don't even need any pain meds. They have very, very little pain.
Oh, you can hear the dog snoring.
And that's a function of, I think, just the nerves are just not as good.
Not
so
as good.
I would agree. Younger patients are harder to rehab.
And do you feel like women too are faster, or it doesn't really matter?
I don't know if that matters. I think in terms of pain tolerance, what I've noticed is the older Asian woman
There it is again, the older
tends
Asian
to
woman.
deal with the pain the best. I don't know if it's purely a cultural thing where they, especially say in the Japanese
Yep.
culture, right? Like it's a little bit dishonorable or shame to complain. So they just bite the bullet,
Yeah.
and but
But that's not true for all Asian women, because there are definitely obviously subcategories, right, of Asian that tend to be more demonstrative,
true,
right?
true.
Yeah.
Do you find like pain or anticipated pain with physical therapy is a barrier to why people won't go to physical therapy after having a surgery? Like, does physical therapy make the pain worse?
Yes, sometimes.
Yeah.
So
it
I'm wondering if
depends.
people are hesitant to go.
Well,
If-
I just had
I don't know if that makes sense.
no, it does. And I think that's why going to a therapist that's very, not intuitive, but a therapist that really is thinking about the physiology of what's going on is very important. Like
Like a specialized.
or somebody who just thinks more and also is spending one-on-one time with the patient.
That's probably
Unfortunately,
important.
there are some people that go to outpatient therapy and they just get put on a bike and they just get told to ride the bike for 20 minutes and then
Oh.
they don't really have so I don't like that. Like that's why I tend to be a little bit more particular about where my patients go for physical therapy just
Got it.
because I just through experience I kind of know like okay, these groups do really take care of our patients really well and I don't get patients coming back complaining.
Yeah.
But the other thing that is true is over aggressive therapy is not good because it just causes like I just had a guy come back to the ER who was doing great. And then he said he went to a therapist and the therapist, he's screaming and he said the therapist just said, I got to get your knee to the bend this much. Like sometimes a younger therapist or an inexperienced therapist
Yeah.
think my job is to get your knee to bend to 120 degrees. But I mean, that'd be nice, but not everybody is going to get there. And if you crank on somebody's knee 2 weeks after surgery, you're just going to cause more inflammation and swelling.
Yeah.
Now their therapy is even harder. So there's a
Right.
balance, right, Chip? Would you agree between pushing a person and not causing too much pain and right? Maybe talk about that a little bit.
That's absolutely true. We found out that there's no need to crank on people's knees. Once in a blue moon, there is somebody who will come in with a pretty tight knee, and even that's kind of a weird thing, because I know that you've taken some patients into the OR to do a manipulation, and you said as soon as they knock out, the knee bends, no problem
Yes.
at all, right? Where we're in the clinic and we're trying our best to bend their knee. But, at a certain point in time, if you are having to crank on your knee that much, it's time to back off a little bit. And
Yes.
and then sometimes, funny enough, when you give the patient a break from therapy, they actually do better.
Yes.
Oh,
So
just some time to heal.
yeah.
And also some time for the swelling
Yeah.
and the inflammatory process to just calm
Calm
down.
down.
And then the tissues get softer, and then they don't have as much almost like, so this problem that you were talking about where they go to sleep and then the knee bends easily is really guarding.
Yeah.
Yeah.
They're mentally they're in pain, so their muscles tighten up, and then they're not going to want to bend anymore because they're protecting their obviously their sore knee.
Yeah.
But once they're under general anesthesia and their body's just relaxed and their muscles relaxed, their knee bends a lot
Much
better.
better.
I'm probably a little bit aggressive with taking people back for manipulation under anesthesia.
And that has to be done in a certain
Yeah, like I like to have it done
Timeframe, right?
before 3 months. Like I prefer to have it done within 2 months because
yeah.
When do you do that? Like if,
So like for example,
like a shoulder, knee, and hip, you do that for?
just usually just for knees.
Just a knee.
Yeah,
Okay.
just because, but I'm not sure. One day we'll have Ed Weldon come and talk about it when shoulder manipulations are appropriate.
Yeah.
But for knee replacements, it depends on a patient's preoperative range of motion, right? So like if you come
Okay,
to me
so you
and you're-
guys do all the testing pre and post.
Well, if your knee, say like you come to me for surgery and your knee goes from full extension and you can bend it to almost your butt,
okay.
right? The knee replacement is a man's best replication of what God gave you, right?
Yeah.
And it's not that good. So there's no way after a knee replacement you can expect that you're going to have the same range of motion.
Oh, so you'll never get that range
if
of
you
motion.
could touch your heel to your butt
Yeah.
before surgery, I tell people don't expect that. You're gonna
Okay.
the surgery is not intended to get you to be normal.
Oh.
The surgery is intended to hopefully make you better in terms of pain.
Yeah.
But not necessarily better if your range of motion is that good. But if you're really stiff before surgery, like let's say this patient had long-standing arthritis, they can bend their knee only like they can get like 20 degrees short of full extension and they can only bend it like 70 degrees. I usually tell them, I almost can guarantee you your knee motion will be better, but it will not be as good as somebody who was more flexible than you before surgery, right? So there's an optimum, range that you'll get. And we actually show, we haven't really published that study yet, but so I do tell people with very flexible knees before surgery that you will most likely lose some. For people with stiff knees before surgery, you'll gain some. But we also kind of judge who we're going to manipulate based on what their preoperative level is. Because if your knee motion was 1 to 140 before surgery, and after surgery you're 0 to 110, you might be a little disappointed that, I wish my knee could bend more. And I wouldn't recommend a manipulation at that point. Some people really, really want it, and they may gain a few more degrees. So we're kind of collecting data on that study now to see how much more motion people gain after the manipulation, right? But I'm a big believer in it, that it's because most people we see, they do much better afterwards. Just give them a little bit, break up some of the scar tissue in the knee, and they do much better. There are a rare few that do not get better, and there's something else going on that, we can't, but that's very rare. Most people do better, I think.
I would agree with that.
Yeah, even if just a few degrees. So I'm pretty aggressive with doing manipulations.
Yeah.
under anesthesia. Because if we can get you like just an extra 5 degrees or 10 degrees, you might be happy with that, right? And it's such a small thing to do.
Yeah, most people, they don't need 130 degrees.
Yeah.
I mean, I tell patients all the time, probably the only thing that you won't be able to do is squat.
Yeah.
You know, like some people, they want to squat all the
Yeah.
way.
Or go downstairs.
Yeah, because,
Oh.
but even to negotiate stairs fairly normally, you only need about 105
Yeah.
degrees of knee bend, right? So, but some people, they get fixated on that number, you know, like, oh, I want to bend my knee 120 or 125.
Yeah.
And, you know, but
What are some just minimal goals that you guys have for people with a knee replacement or a hip replacement? Are there any kind of minimal goals that you want them to achieve?
you mean like, what do you call it? Hallmark or?
Yeah, you know.
Yeah, usually I usually try to make sure they have at least 90 degrees of knee bend.
Okay.
Probably within first couple weeks.
Okay.
If they're only at 70, I begin to monitor them a little bit closer.
Okay.
And then
And 90 degrees is like
Like, yeah. So you can.
like this.
Yes.
Okay. Like hanging off a chair.
Exactly.
yeah.
Okay,
Right.
okay.
Yeah. And then everybody kind of progresses their ambulation at different paces. Some
Okay.
people will stay with a walker for like 3 weeks, 4 weeks.
Oh.
Other people, first week, they're walking with a cane.
Oh.
Especially the hip replacements. I've seen people walk with no device within the first week, right?
Yep.
It's unbelievable.
Yeah.
So, but those are the big ones. You know, the other big one is to check if they can do a straight leg raise. That's like say
Oh.
you're laying on the bed and you can tighten your thigh muscle and lift your leg straight up without a lag like this. And that varies because that kind of dictates how fast you get off of a walker. Because if your thigh muscles aren't strong, then then you're gonna struggle a little bit when you walk. And also when you try to get yourself in and out of cars, in and off the bed, things
Yeah.
like that. So we check those things and we try to get them to be able to do that fairly rapidly.
Is there anything that people should prepare themselves for at home when a family member is getting a knee or a hip
For
replacement?
sure. Yeah. All the way from transportation,
Okay.
right? And even that.
Like, is a high car better to pick them up or a low car better to get them in?
That's tough because it's easier to get into a low car, but harder to get out.
of it.
And yeah, if you ever talk to somebody who, oh yeah, my husband picked me up in his lifted Bronco, it's super hard to get into. Yeah. So
Like little things like that. When my mom had her surgery, I was like, do I need something in the shower? Do I need,
Yeah.
what do we, what can we
Yeah.
anticipate?
the one probably the biggest consideration is stairs and curbs. So you'd be amazed at how a 4-inch curb or step into the home is a huge barrier when you have a hip or knee replacement, especially a knee replacement, and you're with a walker. So installing grab bars or rails beforehand is a smart idea. And then of course taking a bath.
Yeah.
Cass and I talked about this earlier, right? Is that taking out as you get older, taking out your tub and putting a pan in there so that you don't have to step over the ledge.
Basically like a walk-in shower.
Right. Yeah. That's a really smart thing to do, and to equip it with grab bars.
I think this is a point that I think really we should stress is that I do tell my patients too, right, that if you're lucky enough to get old, you're going to need it. So it's a good thing to start thinking about. Like even for me, I mean, I'm still hopefully healthy, but at some point I may need some grab bars in the shower. Safety bars. Why not install them? Yeah, they look a little, I know,
A little geriatric.
Yeah, it looks a little geriatric, but it'll come in handy
Yeah.
in the future, right? Like we changed our tub to a walk-in shower as well. And it makes a big difference, right? Just
It
makes
does.
it easier on yourself,
Yeah.
right?
Even after like C-section, right?
Yeah.
We have a walk-in shower, and thank God, because I couldn't get into it.
Yeah,
Like a step shower. I mean,
Yeah.
you could, but it's just really painful.
yeah. So I think those kinds of things are good to prepare for. But do you recommend a shower chair? I tell
Yeah, I
patients.
always have that question.
I tell patients, I think it's easier for you to, if you can, and you're not too unsteady, to just stand in the shower.
Well, it depends on how long you take a shower.
Yeah, true.
So, you know, if somebody is, I don't know.
But I would think it's harder because I've seen those shower chairs and it's
To like get up and
if
in.
you're in a tub and you have a shower chair, that can be a little dangerous because you got to make sure that that shower chair is in a stable position.
It is, but they make chairs where, so say someone still has their tub.
Yeah.
Right? To basically step over
Yep.
that tub can be kind of challenging,
Yes.
especially if you don't have a grab bar.
rail. Yep.
So
Yeah.
the shower chairs sometimes can extend outside the tub, so you sit on it and
Oh,
it
and
just
you
kind of
slide in.
you just slide in. So
Got
it's
it.
safer for some people.
Got it.
Or
That's
if
a
some
good
people
idea.
fatigue quickly standing
Yep.
or whatever, you know, then they might want to sit down or have that option, right? So, but either way, you know, because you know they're not going to be taking a shower for 2 hours.
Yeah.
I hope not, at least.
Yeah. Yeah.
Interesting.
Yeah, but
And what other tips do you have for patients after hip or knee replacement in terms of preparing the home? You know, because I think a safety evaluation in the home is
Yeah.
also important because, you know, some people, you know, like we have some patients that are effectively hoarders, right? And, you know, no, seriously, like kids will come in and say, oh, my mom's house is just full of junk. And then mom is or grandma's
Yeah.
telling me that I cannot get around the house with the walker because they don't have space.
yeah.
Or
well,
even as simple as like running, like runners or carpet, right?
Yes.
Like rugs.
Yeah,
You have
dangerous.
Should you remove those things or just
you should
leave
take
them?
out all the throw rugs. Maybe at the edge of the stairs. You want to have good lighting, obviously.
Yeah.
The edge of the stairs, you might want to put a fluorescent tape or something. And you know the other one that people don't really think about much is pets. So you know when you have like little pets running around, I'll tell you,
That's true.
you have to be
trip over 'em.
careful. I have had people actually fall tripping over their pets.
Mm-hmm.
Yeah, right. And larger dogs too. I've actually had.
I've had in my family. Yeah.
I've had some of our patients. Actually, this is rare, but it happened where dog knocked her over,
yeah.
and you know they break something.
Yeah.
Yeah.
Right.
That's right. Pets.
So
Yeah. Or you could be at the dog park and have a 70-pound dog run
run
your
into you.
knee.
Yes, exactly, and just break your knee.
That actually just happened to somebody.
Really?
Yeah, I remember this story.
A
But-
dog can break your knee.
Yeah, you know, like a big dog running around chasing another dog, and it just happened to hit you
Yeah.
like a linebacker hits your knee. You know,
Yeah.
cause a tibial plateau fracture
No way.
or
Gotta
something
watch
like
out.
that. Yeah.
My dogs. Not this guy though.
Yeah.
No, that kind. Yeah, that's
Yeah.
the kind that you trip over.
Yeah.
That's right.
Yeah.
Yeah.
Yeah, that's interesting. We always get that question like when people are anticipating their surgery, okay, what things do we need to line up at home to make sure everything's okay?
Yeah. The big one I tell you is still stairs.
Hmm.
Because you know a lot of homes, right? 2-story homes.
Mm-hmm.
I'll tell you, if all the bedrooms and say the full bathrooms are upstairs,
Mm-hmm.
that's a huge obstacle. You know, well, most homes will have a rail. You know, and you can get by with just one rail because you can sidestep up.
Yeah.
But still, to go up and down is pretty humbug.
Yeah, it is.
And I think this brings us back to our point. You know, your point about if you have somebody do a straight leg raise and they cannot keep their legs straight, right? What it's indicating is just quad weakness.
Correct. Yeah.
And so
Yeah.
weakness is still, I think, like the biggest problem for people
Yeah.
recovering from surgery. Because I always tell people, like, for somebody who's in shape and so in shape and is strong, having one rail and having everything on upstairs or downstairs is not a problem, right? If you told me, can you go upstairs with just one leg and holding the rail, easy,
Yeah.
right? I don't even have to use my other leg.
Yeah.
But if you tell somebody who's weak and cannot even hold up their own body with 2 arms, right, and their other leg is
rough.
weak, it's rough, right? So, you know, keeping yourself having a certain level of strength capacity is very, very important.
Yeah.
Right? That's why a lot of these longevity indicators, like
Yeah.
how long you can dead hang, quadriceps circumference, grip strength. are
Really?
are all indicators
Quad
that
circumference.
yeah, just because if you have more muscle.
Well, I get tender thighs, but I don't think that helps with my strength, does
No,
it?
but if you look at
the
people as a
Portuguese.
whole, if you look at people as a whole, right?
I guess
The thinner, frailer ones don't
Yeah.
do as well.
That's true.
Even
know?
single leg balance,
Yep.
right? Because going back to this whole neuromuscular
Balance.
control, right?
Yep.
I mean, I think probably the number one reason why elderly fall is not because they're weak. It's usually because of their balance reactions,
yeah.
right?
Yep.
That's why I tell so many guys, men
Resistance
especially,
training.
Yeah.
stay out of fruit trees, stay off the ladder,
Yep.
stay off the roof. You think you can do it, but you cannot.
Yep.
You know, so but you know, when you actually, and you can speak more to this, right? So someone has a pretty bow leg.
Yeah.
And then you go in there and whatever you do, you straighten it, you
Yep.
derotate the tibia, whatever you
Yes.
do, right? That changes their perception of balance,
That's right.
right? And so that's one thing. Some people will be strong, pretty good range of motion in their knee, but their balance is not good.
Yeah.
Right? And so they become a fall risk.
Yeah, but that's a more complicated thing than just the alignment of their joints, right? Because balance is also a central
Yes.
thing. And I think
The
as
brain.
we all get older, I mean, even for myself, I can tell that
It's
my
not
balance
as-
is not as good as when we were in high school playing ball, right?
For sure.
Like things that we could do in high school, we tried it. And it's like you feel like, oh my God, what happened to me,
Right.
right? But yeah, so I think that is an important point, and I think that's why when we had this discussion on the previous episode about depends on the car you bring me, right? If
Yeah.
you bring me a junk car and I change the tire, it's still a junk car,
Mm-hmm.
right? But if you bring me a good car and I change the tire and we do a decent job,
She gonna run good.
The car will run well.
Yeah.
So it's the same applies, I think, for
I have a question, and again, simple mind maybe, but does it matter as far as physical therapy if you do what you guys were saying, anterior or a posterior approach on a hip? Does that make a difference the way you do the surgery?
Okay, my subjective opinion on that is yes, right?
Okay.
And there are many
Sorry, I know
reasons
this
we
is
could-
probably really
no, it's
nuanced
no,
question.
it's not. It's but and posterior surgeons who do posterior approach and do it well.
So instead of the front, the back.
Yes,
Okay.
the traditional way, I should say.
So they traditionally do hip replacements
Through the back,
the
through
back.
your okole.
Through your
basically,
okole,
yeah,
okay.
right. And we do it through the front.
Okay.
Which is obviously that can be explained better later, but just those two differences. I stopped doing the posterior approach because a long time ago, this was back in 2005, right?
Wow.
Yeah, because that was what most of my training was in. And this anterior approach has really made it so people recover, to me, a lot quicker. Plus, just for the fact that you don't have to do any hip precautions.
That's huge.
What does that mean?
Hip precautions mean after a surgery done through the back, generally speaking, you're not allowed to bend your hip past 90 degrees. You're not supposed to cross the midline with your leg, right? Because
Like no crisscross applesauce?
no crossing your legs. You're not supposed to bend down to
cannot
pick things
bend
up.
down.
Yeah, right?
Because it might pop out
Because your hip might dislocate
backwards.
backwards.
Oh, okay.
Because with the surgery, you have to go through the posterior muscles and you have to actually detach and then repair them.
Oh, you repair the muscle.
Yeah, you have to take the muscle off the bone
Oh.
so that you can get the hip open and then do the surgery.
Got
But
it.
with the anterior approach,
Oh, yeah, you don't have to.
we don't have to cut, detach, or repair any muscles. We
Wow.
just go between the muscle groups and we can get the surgery done.
Interesting.
And we can do it under image guidance. So I think, you can get the mechanical dimensions correct much more consistently.
Interesting.
Right, and the studies do show that. But obviously, a posterior surgeon would argue that the differences are not that great.
Okay.
But I think like I wouldn't go back to doing posterior approaches,
Yeah,
just because people do so much. It's so much easier for me.
Yeah.
Right? I don't have
And
to
their
worry.
physical therapy after is different if you
Yeah,
have
like
a
maybe you
posterior
can
approach?
Way
maybe you
different.
can talk
Way
a little
different.
bit
Oh.
about
Okay.
what do you see as differences between anterior and posterior approach in terms of physical therapy? Because obviously I see the surgery and I see them, but the therapists really see
Right.
the struggles that they have
Yeah.
Yeah.
throughout their recovery period.
Well, the posterior approach for sure. I mean, I've seen incisions back in the day like that
Oh.
long.
Yeah.
Huge.
Oh.
And then they put staples. So there's all this superficial scar tissue.
Mm-hmm.
And, the posterior approach, definitely patients are more sore.
I bet.
And then having to pay attention to the hip precautions, even in therapy, is kind of humbug.
Really?
Yeah. Yeah. So patients have a hard time putting their socks on. They have to use, some
you
kind
have
of
to kind of
tool.
bend.
Yeah. Yep, they have to be careful of internally rotating their hip or crossing their legs, like he was saying. Sorry. But yeah, anterior hips, gosh, they come in and they like full weight bearing, no problem at all, you know. And you once told me, right, to actually dislocate an anterior hip would require quite a bit of traction force, right?
Traction and rotation, right? Which are
To like pop it forward.
to put your leg in a position where you would be likely to do that.
What is that? Like a
It's like you got to put your leg back and you got to rotate your foot out.
And the person would have to probably be completely relaxed, right?
Yeah.
Like,
Yeah.
yeah. But
Yeah, but we've had some unusual circumstances where some people did dislocate their hip. One of them that sticks in my mind is one of my patients, younger, healthy girl, yoga. She was in her yoga class after surgery, and I guess her instructor.
oh no.
So she was. I guess there's a position where you lay on your back and you butterfly your
Yeah.
legs open, and the goal is to put your knee so that you can touch
Touch the floor.
the floor.
Yeah.
So he came and he pushed her leg down and then popped it out the front, right?
Oh.
But he didn't know, right, that could happen. And then once that was reduced and we said, okay, just try to avoid
Yeah.
that. Perfectly fine right afterwards. You know
Really?
what I mean? Yeah.
Oh.
So, but as an example, right, that's an unusual thing that you would have to do.
Right.
Whereas
Interesting.
Posterior approach, it's very easy to violate your hip precautions because you're sitting down eating dinner. Well, you drop your fork,
You're like, "Oh,
you
let me
bend
pick it
over to
up."
pick up your fork.
Yeah.
You don't realize that your body is going like this to your hip because it's such a normal motion.
Yeah.
And then pop.
But it's not the same for knees, right? Knees are just one way of doing a knee, and you don't
Yeah,
have
no,
any.
there's other different ways of doing
Oh.
knee replacements too. Like when I first started my practice, I used to do a lot of minimally invasive knee replacements where we make the incision very small, and I was so proud of myself, and
Yeah.
we would show pictures and whatnot. But when we studied our patients
Mm-hmm.
for that particular surgery, we really didn't, and I really thought the data was wrong because I was such a believer that this is supposed to be better for people.
Yeah.
But it turns out the people doing regular knee replacements were recovering just as fast.
Huh.
So I stopped doing that minimally, and then I had to go through a year or so of explaining to patients why I don't do it that way. But if it's not as effective and if
Yeah.
it makes things more difficult to do, then it's probably safer for patients
and
to have.
nobody cares how big their scar
Yeah.
is, to tell you the truth. At that point, when your knee is that sore.
Only knee and hip. They do care about their C-section scar.
Yeah, but that's because these are younger women.
Oh, is that what it is?
I think so, right? Because only childbearing women are having C-sections, right?
It's true.
But my patients are all 65, 70.
And they're like,
Plus,
we are
yeah.
not wearing any.
Yeah. But I always tell my older women, because I do occasionally get them asking me, like, oh, how big is the scar going to be? I'm like, you know what? Next time you go to the beach, just wear a thong. Nobody will notice your scar, I promise.
Terrible.
My patients all have good senses of humor, but they get it. It's like, yeah, that's true. Nobody's going to notice your, yeah. Okay. Anyway, I don't know. I think we kind of used up our time on that topic. Any other questions that you may have or?
I think that's it. I have a lot more questions regarding the ladies. So we'll revisit that. We'll get to that soon.
Yeah, so we're going to end this discussion here. And again, thanks for being here to talk to us about sort of
You're
some
welcome.
therapy
Thanks for
issues
having
regarding
me.
post-op hip and knee replacements. There's a million things to talk about. Like, I wish we could have another episode of this, which maybe we will, just to talk about some other things. But so anyway, thanks for joining us for this episode on From the Inside Out. Again, don't forget to like and subscribe. And our next episode is again going to be with Chip Yamaguchi, and we're going to talk about some OBGYN related issues and post-operative physical therapy questions.